Hello and welcome to the Neurocritical Care Society podcast. Today on our Perspective series, I have a guest I've been wanting to have on the podcast for quite some time, Dr. Eelco Wijdicks from the Mayo Clinic. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the host and guest and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. But jumping right in, Dr. Wijdicks really established the specialty of neurocritical care at the Mayo Clinic in 1992. He is currently a professor of neurology at the Mayo Clinic College of Medicine and chair of the Division of Critical Care Neurology since 2003. Among his major research accomplishments, he originated the full outline of unresponsiveness, or FOUR Score Coma Scale. And additional areas of study include the history of medicine and specifically the history of neurosciences. Many of those historical features can be found in the journal Neurocritical Care, of which he was the founding editor-in-chief. He has over 1,000 research papers, practice guidelines, topic reviews, book chapters, and editorials to his credit, and several books on the history of medicine and portrayal of medicine and neurology in cinema. Dr. Wijdicks, thanks so much for joining us on the podcast. I'm really excited to have you on.
Thank you.
We always kind of like to start with sort of your origin story a little bit. So how did this all get started for you? I saw that you completed residency in psychiatry and neurology and then did clinical neurophysiology. When did neurocritical care come into the picture and why?
Yeah, thank you. Well, I originated from Holland, and there in the 1980s, when I did my residency, we did a year of psychiatry and a year internal medicine before we went into neurology. And that was just pretty much standard at that time. And the psychiatry part has disappeared, I think, unfortunately. But and in general, when you look back at how things started, I think we're in general always tremendously conditioned by the environment we trained in. And when I started in the Erasmus University in Rotterdam, there was a group that was interested in management and research in subarachnoid hemorrhage. And it came late to the party, but it was already established. You may remember Rien Vermeulen, who became my mentor and a very good friend, still a very good friend, who organized the first tranexamic acid trial in subarachnoid hemorrhage, double-blinded trial that found that if you give tranexamic acids to patients for about a week, then you can significantly reduce rebleeding, but at the expense of infarctions and worse outcome. And this was in a time that patients with subarachnoid hemorrhage, at least in Holland and most places in Europe and in the UK, were treated late. Their surgeons felt that the brain was angry, we shouldn't go in and clip the aneurysm immediately, let everybody and the patient rest. And that led to, of course, rebleeds. And the way to try to prevent that was with tranexamic acid. And these were infusions. Unfortunately, we now know that it is not useful. In fact, I think what I can remember is that the CT scans at that time showed horrible infarctions in the patients who were treated. So it did something good and it did something bad. I can remember that one of the British neurosurgeons said, we have a treatment here that works, but does not help. And that is, I think, still the situation with tranexamic acid. So I got into this group that did research on subarachnoid hemorrhage. We had two ICUs, one for trauma that was run by, at that time, I think he was just in residency, Andrew Maas, who is now in Belgium and professor there and still very active in TBI. And he was part of the trauma. Their surgery had a separate trauma unit, and we had a separate neuro ICU, which is sort of in between a step down and a ward where patients with subarachnoid hemorrhage, but also patients with other neurological diseases were admitted. So I was immediately got into this. We all were exposed really immediately to patients with subarachnoid hemorrhage and critical illness. And because I was allowed to be in that group and started studying particularly important question is, why do patients with hyponatremia develop cerebral infarctions? And we didn't know that. We thought it was all the tranexamic acid, and it turned out to be that the fluid restriction that we were giving to those patients did bad things to these patients, in addition to tranexamic acid. And that led to my research that was in trying to figure out the mechanism of hyponatremia after subarachnoid hemorrhage. At that time, there was a paper by Paul Nelson, a neurosurgeon, who questioned the inappropriate 88 syndrome. We questioned it. We saw a significant polyuria and natriuresis in these patients, and we couldn't think that this was inappropriate 88 syndrome. And so we found eventually that it was in cerebral salt wasting syndrome, and these patients were hypovolemic, and then we were also really fluid restricting them. We can understand in patients who have severe vasospasm, but the consequences of all that management is. So that's
for our younger listeners, sorry to interrupt, for our younger listeners, would you mind, maybe this might seem crazy to them at this point, right? The idea of fluid restriction and subarachnoid hemorrhage. I'm wondering if you can talk a little bit about the thinking back then about why fluid restriction was part of the management of these patients.
Well, fluid restriction was the management of inappropriate 88 syndrome. And so all patients who had hyponatremia were considered inappropriate, having an inappropriate 88 syndrome, and therefore were fluid restricted, and not only free water restricted, but really fluid restricted. At that time, it was very common to treat patients also with aggressively with antihypertensive, something we still do a bit more, but this was continued often throughout the observation period. Mind you that these patients were treated around, I would say, 10 days following the ictus, the initial rupture. So it was the mistaken idea that these patients had inappropriate 88 syndrome. Fluid restriction on top of a patient who was already hypovolemic would then lead in a severely affected patient with severe cerebral vasospasm would lead to watershed infarcts. That was the idea. And so we thought that was a important finding, and then we went measuring fluid balance and measuring plasma volumes through assays, where we would then confirm that these patients became hypovolemic. And so that was the topic of my PhD thesis at that time. And that led me eventually to become on staff in Utrecht, which is the central part of Holland, where the university in Utrecht. There, I figured out that the only way to understand this natriuresis is to do an assay in atrial natriuretic factor, and that was in Mass General, and that's where it all started. How I got into the U.S. I contacted Alan Roper, and I asked him, "Is it possible for me to come there for a few months to measure in your patients with subarachnoid hemorrhage atrial natriuretic factor?" Mind you, that was not available yet. I think Mass General had the only institution that was able to do atrial natriuretic peptide assays. Hopkins also came shortly thereafter. And that led me to come to the U.S. And there's, of course, a bigger story.
Yeah, that's wonderful. Alan Roper was one of the first guests on the podcast, and he spoke to us at length about sort of developing the neurocritical care unit at Mass General. I'm wondering, what were your first thoughts on joining that unit and seeing the differences between the way things were practiced in Erasmus and Utrecht versus how they were in Boston?
Well, I think it's not exaggeration to say, I'll be exaggerating to say that Alan Roper is intrinsic to the making of me. And when I got to the US, I was basically a research fellow. I had the opportunity to round with him in the unit and see the intensive care unit and see the idea of how it would be possible for a neurologist to manage patients in the neuro ICU, including neurosurgical patients that were in that combined neurology and neurosurgical ICU. And I think I was his first fellow. And so I was basically only there to do that essay. It was funny because they told me, well, we can definitely do your essay, but you have to do it all by yourself. You have to do it by yourself. And so I said, okay, I'll try. And I had to learn it, get blood samples, and then do the essay myself under supervision. And so that was my basic goal. Then it turns out to be that Mass General at that time had a large group of patients with Guillain-Barré syndrome. And Alan asked me, I have a lot of material. Would you like to stay longer? Then we can look at that material. And I said, well, then I have to. I was fully employed in Holland, and I have to talk to them if that's okay to stay longer. And they were graciously enough to let me stay for another year. So I stayed about 18, 19 months in Boston, working largely on GPS, which is not my topic of interest, and that's how it often goes. You have an idea, or you have a topic that you're interested in, and then there's suddenly another topic that you might be interested in, and which became, for me at least, most of the time became my major topic of interest, and that led to us writing a book on Guillain-Barré syndrome that I think is still in print. So that was a wonderful time. I had a young family. We were living close to Boston in a small community called Needham. And there was a dispute there of a family that didn't know what to do with a little town next to a turkey farm. And so they wanted to rent it. We went to the turkey farmhouse and stayed there for 18 months with two young kids. And that was basically heaven for us to live there and be in a very open place, except for the 1,000 turkeys that were there. And we're also readied for Thanksgiving. So that was an interesting time at that time.
That sounds really lovely and reminds me of memories in my internship at Beth Israel Hospital, as turkeys were known to sort of stride through the lobby from time to time and cause a ruckus as they strolled through Brookline. Take us then to the next phase after that. How did you end up at the Mayo Clinic?
So I had to go back to Holland for 2 years, and then I came back to Mayo. I had an interview while I was in Boston, a long interview, several days of interview. Jasper Dowie was the chair at that time. He was really instrumental by thinking that it should be possible at Mayo to create an intensive care unit. There was an intensive care unit, largely post-operative neurosurgery, run by anesthesiologists who basically did post-operative care, and all the medical acute neurological conditions such as GPS or myasthenia gravis or encephalitis and meningitis all went to the medical ICU. So, but he also felt that it would be, there was an approval for building a new neuro ICU, and we're talking here now in 1992. In 1995, the new unit opened there. And that was indeed also, as it is in many other countries and also many places here in the US, a combined neurology and neurosurgical intensive care unit. And so I was hired to start it up together with Jimmy Fulton, who also did a fellowship in Mass General. And so we started. And my concept was at that time, and we still continue to have that idea, is to think that acute neurology or critical illness neurology is throughout the hospital. And you cannot just say, I'm only going to take care of patients in the neuro ICU, but you also have to do the consultations in other ICUs. And even if it's necessary in the emergency department. So my philosophy was that I need to build a system that makes us be part of the emergency room, have representation there, but also do all the consults in other ICUs in the hospital that we worked in. There was another hospital, Methodist Hospital, where there was a large transplant unit. So, and that's what it still is today. We know when the patient comes in the emergency room, we can triage them to our unit if necessary. We are involved really in the first hours of presentation, and then, of course, take care of them in the neuro ICU, but also see patients that are in medical ICUs or surgical ICUs and tell them, and sometimes bring them to our neuro ICU because you think they're better handled or better observed by our nursing staff in the neuro ICU. So I felt that that was a relatively new idea, but would get us better in contact with all patients who had an acute neurologic disease.
Right, right. As you were sort of establishing this triage system, I imagine maybe there were some tensions with where certain patients were best treated. For instance, maybe bacterial meningitis probably went to the medical ICU traditionally. And I guess how did you navigate those challenges, and what diseases did you find were particularly well suited to being cared for under the neurocritical care unit?
Yeah, if you start any new specialty, and I think we were really in a group that all had similar problems, is that many felt that a neurologist in an ICU, neuro ICU, is a really bad idea. A neurologist should not be there. That's this. Why would they even be there? And many other specialties, and for some neurosurgeons, but neurosurgeons have never been an issue for me or for our group. And some, but it was more with anesthesiology that felt that we should not be part of that. And many of the anesthesiologists also were running the medical and surgical ICUs. So yes, there were tensions, and yes, there were turf battles, and I think it gradually just got better over time. It's something that is not so easy to do, but I think what we did is that we just showed everybody that we had the knowledge and the skills to take care of them, and even that we were willing to make the patient to improve the patient's outcome, and that we were really concerned about these patients when they were in medical ICUs taking care of non-neurologists, and we felt that they needed to be in a neuro ICU. And I would think that gradually everybody came to this to their senses and felt that that was indeed better to have them in a neuro ICU. It's very slow process. It's always is slow. If you look at other specialties or subspecialties, they always has the same problem. Why do you want to do that I'm already been doing for so many years? And who are you to tell me what to do? Is always the case. And we felt that just by I still think that the fact that we did the consults in other ICUs made us more present there too, and made us more part of the group than if we would have been just solitary in our neuro ICU. So I think that definitely helped.
Yeah, that makes total sense. I think we've been facing sort of some of these issues throughout the history of neurocritical care, and you've really stood out. I've heard you called the historian in chief of our field. I've really enjoyed some of the pieces you've written in the journal. Can you give us maybe just a brief story or a reflection on some aspect of the history of neurocritical care that maybe most people don't know or should know?
Yeah, so I've done, and I don't know how it even got there, but 75 essays on the history of neurocritical care, and I promised Michael Derringer that I would do, I think, first 25, and then went to 75. And now it's going to be a book that is almost finished, where I would took these articles, but also expanded the ideas. I always felt that when I read papers on the history of neurocritical care, that we start with the polio epidemic, and that's partly true. But at that time, neurologists were not taking care of polio patients. There were anesthesiologists, and neurologists were not so often involved in these patients who were in iron lungs or who had it, or eventually were placed on ventilators. Angstrom was, of course, the first ventilator that was used at that time. So I always wondered, how is it that what we currently know, when we go into to the unit and see a patient with meningitis or see a patient with traumatic brain injury or subarachnoid hemorrhage, where does all that knowledge come from? And who, if you open up a textbook, why is that true? And who told the person that that's the way it should be? And so I start digging in every disease and every clinical sign and try to figure out where it all started. And that was basically my premise, is to find out, and I did find out that neurocritical care, and a neurocritical care is obviously the care of the acute neurology patient, but acute neurology, where patients could die if there was no mechanical ventilator, started much earlier, and even started with our good friend Thomas Willis, as we all know, from the Circle of Willis, who basically was one of the first persons to describe a fatal manifestation of myasthenia gravis. And if you read his description or later descriptions, it's exactly what we know now. And so I wanted to go back, and I think I went back to about 1850 or so, where I could find that many physicians were already describing what we now know, and that was basically the part of my thesis, that yes, the start of the history of neurocritical care started much earlier than the polio pandemic or epidemic. And now there were neurologists who were taken care of. I found that Russell and Fred Plum and also A.B. Baker were interested in patients who had polio and were on a mechanical ventilator, and did work. In fact, Russell in the UK built one of the first ventilators for patients with polio. So there was interest, but it was very scattered, and most of it was done by anesthesiologists. So I think it's a bit of a misconception to think that our field started with the polio pandemic, and it's a good story. I mean, it's a neurological disease which led to mechanical ventilation, and which led to basically the foundation of critical care medicine as a whole, but not so much neurocritical care. So I would think that it is started much earlier. Our descriptions of the disorders that we now treat started much earlier. And that's what I'm trying to put together in a book that hopefully will be ready before the 25th anniversary of the Neurocritical Care Society.
We'll look forward to it. What do you see as sort of the turning point in these sort of the scattered interest in the early days of neurocritical care, and then when it really became what it is today?
I think the main point was, and I think we've all been part in doing that, is trying to define what our specialty is all about. And so who needs to be in a neuro ICU and who does not need to be in a neuro ICU. And I think that started happening, I think, in the 1990s, early 2000, in which we got a much better idea of what the population was that should be in a neuro ICU. My interest at that time was, okay, so these are the patients that come in here, and they are triaged to the neuro ICU. I wanted to know, they come in and they all look stable, and then they're not, and they deteriorate, and why are they deteriorating, and what's the cause of their deterioration? Much of it was not so much medical complications, but it was also neurological deterioration. And what does that mean, and what does that have to lead to? Does it need a neurosurgical intervention? Does it need a certain combination of treatments? Those were, I think that was more or less a landmark development, that we had a much better idea how a patient with a specific disease would look at day 5, and how the patient would look at day 7, and how the patient would look a month after initial presentation. And I think that was an important next step, that we had a better idea, a better clinical idea what we're dealing with treating of these patients. I think that was a major next step. Apart from all the organization and all the processes and administration of the intensive care units, it was also trying to have a much better handle of what is happening to the patient that you're taking up day and night. And do I understand why this patient is deteriorating? And what do I do about it? And how can I avoid deterioration to a point that we can't help the patient anymore?
Right. You mentioned you've written now 75 pieces on the history of neurocritical care, and you're really known as just an incredibly prolific writer. In fact, when I told some people that you were going to be on the podcast, several people asked, you have to, they asked me to ask, how do you do it? How do you find the time to write? What's your process? Any tips for those who are struggling to finish these manuscripts that are piling up on their desktop? How do you do this and still take care of patients?
Just hard work. And it's the proverbial 10,000 hours. And I learned how to write, I think, I'm certain, when I was with Alan Roper, he taught me how to write. And a book helps. Writing a book, if you never had written a book, helps to do that. And then I found out I could do it. And then it's just a matter of continuing. My writing is typically every day, and I do that. I always were able. What I was reasonably good at, I was always able to find an hour here and there to write, rather than just say I'm going to sit behind my computer and write 500 to 1,000 words. I was always able to do that. In the past, I would write throughout the night. Now I'm early morning, and but it's just a matter of continuing and doing it every day, and trying to write what you like to write about, trying to find a topic, and then trying to find what people would like to read about. And that's basically, it's hard to tell you why. It's probably an addiction too. I would think that's probably what it is. But for me, it has always been a passion, and it has been something that relaxes me after I've been on call for 24/7 to do some writing and to summarize what I've seen, to try to develop new ideas, and then eventually write what I'm writing.
So I love that you really ascribe your writing to learning under Alan Roper as a research fellow at Mass General. I'm a fellowship director myself. How important, in your estimation, is it that we teach our fellows, our clinical fellows, how to write? I think it's very, I don't know if controversial is the right word, but there's only so much we can fit into fellowship these days, and there's a lot of competition for that time. I think writing is critically important. I'm wondering what are your thoughts on that?
Yeah, it is important, and I think all our fellows expect that they would lead the fellowship with a couple of papers. I don't know if I still think that way, but I also feel that it is important to develop a clinical acumen for fellows, and that is also something that I probably have to be more worried about it if they would write a paper. I am. I think it all has to do with mentorship and close mentorship, and which we do. Alejandro Robinstein and I have mentored several fellows and very close mentoring. Alejandro has been absolutely terrific in mentoring our fellows in writing their papers. And so we've always had very close mentorship, and telling them, sometimes you even start with a case report and work your way through a detailed case report, and then eventually, doing rounds. It's simple. There are so many ideas that are floating around that some of them will definitely could lead to look back at the cases that you've done, look back at the material that you have, and try to solve a little problem that came up doing rounds.
I recently checked and I saw that your H index is a remarkable 103. I'm wondering, of all of these incredibly impactful publications, is there one that really stands out for you that you're either most proud of or that you really enjoyed working on?
It has to be the first two ones. The first two that I was lucky as a resident to publish my first two papers in the Annals of Neurology, and I couldn't believe it. And then there was a very long period that I couldn't get anything published. And I thought, okay, I had my good period. But those two papers in which, and I still look back at them, they're from 1985, where I think most of the listeners were not born yet, where we did the two studies on hyponatremia. Were the ones that I'm mostly proud of, because it was something that was not known and rather unique, and I was understood immediately that this could have implications for the care of these patients. So they have to be my favorite ones that I wrote. I'm glad to hear that people like my papers. I'm surprised by the number, to be very honest. I haven't looked at the H index for a while, but I'm glad that they do, and I'm glad that we contribute something.
Now, you've also written several books on neurology and film under this Neuro cinema titles. I'm wondering, maybe we can sort of change the conversation a little bit. What are some of your favorite films?
Oh, yeah. So what I wrote, you mean about the topics that I wrote about, or just any of my favorite films?
Well, maybe we'll stick to neuro cinema.
Okay, so I would think I have a top 10 in one of my books of the movies that I like most. It's if you look at 360 movies that has neurological themes, it's difficult to find which one is your favorite. But the one that I think really is the one that is probably the most close to what we do is called The Death, and it of course has a bad ending, The Death of Mr. Lazarescu. And it's a Romanian movie, and everybody would think, oh, Lazarescu sounds Romanian, but it's basically the combination of Lazarus and resuscitation.
Ah.
And and Mr. Lazarescu developed headaches and was an alcoholic, and it's a true story, in Bucharest. And he was in an ambulance because they felt that there was something more than just headaches. He was confused. And they could not find a hospital that was willing to take someone who was an alcoholic and had headaches. And and the medics were just circling around Bucharest to find a hospital. This movie shows every time his admission to an emergency room, where you could see something that we always have to be very careful about, is called compassion fatigue. So nobody really cares too much about him, another alcoholic with headaches, and why do I have to take care of these patients? And come on, let me just do some more serious work here, including the neurosurgeon there. That's it's a comedian, but it makes you wonder why this happened to him. And eventually he dies because of a subdural hematoma, as you can imagine. And the film taught me that, and I think it's a film that everybody needs to see, tells you that when you are part of a neuro ICU, a part of the job that you do, there is really a concern that you may develop this phenomenon called compassion fatigue. It's not burned out. It's maybe part of burned out, but it's that you are getting less interested in patients that you take care of, simply because you don't have the resources, simply because you are tired, simply because there are other elements that make it difficult for you to be on top of your game. And so that film struck with me, and I think is an important film for everybody to see. And that's the one on top of my list of I think about 160 or so films that you all can see and see neurologic themes in. There are many films also with coma and awakening from coma, or even horror movies in which someone is able to go into the mind of a comatose patient. There's a lot of weirdness out there, and I thought it would be interesting to summarize that and to look at it. I was basically really interested to see how neurology looked through the lens of the filmmaker, and neurological disease could have impact on our relationships and how we deal with it.
That's great, and such a good lesson from the first film you mentioned. I'm wondering, is there another film that you might recommend to those outside our field? Sometimes people ask us, what's it like in a neuro ICU, or what do you do? Is there a film out there that gives some type of accurate depiction that lets people understand at least a little bit about some aspect of what it's like to work in the neuro ICU?
No, there isn't. No, it's the only there are films with neurosurgeons. And there are films where you can see patients in ICUs, but there are not many films made in neuro ICUs that I would think is of interest to look at. There's a lot of trauma, obviously, and filmmakers found out that putting a protagonist in coma and or trauma and coma, then you can change the plot immediately. You're probably aware of the movie regarding Henry, in
Yes.
which Harrison Ford gets shot in the head, and the neurosurgeon tells his wife, well, he was very lucky because he hit the frontal lobe, and because he hit the frontal lobe, he should be doing all right. And he did. In fact, he woke up, but before I think he was a lawyer. Before he got shot in the head, he was an aggressive, nasty lawyer. But after this traumatic head injury, he was a very kind individual, compassionate, taking care of everyone that needed help. And basically, the opposite what we see in traumatic brain injury, that nice people become nasty, or nice people are not, or have a major personality disorder and have difficulty managing or families have difficulty managing their changed personality. That might be the closest, I think,
Got it.
that you may want to watch.
Yeah, my wife hates watching any medical films or television with me because I just can't stand some of the inaccuracies. The biggest one for me is when they show the comatose patient who's not on a ventilator, who basically looks like a GCS of 3, and they're just sort of comfortably sitting in bed. Do you have a certain kind
They
of
all,
feeling
yeah,
about?
I call that the sleepy beauty phenomenon.
Yes, yes, yes.
They all look well tanned, and they but often with a smile on their face. And so, I should say that why is this interesting? It is, on the one hand, problematic that the way we are represented is different. But it's also interesting to look at to see why filmmakers have such a bias. And I felt that if filmmakers feel that that's what neurology is all about, then I would think the lay people have similar thoughts about that. And so film or any art form creates sort of a alternative world where sort of an alternative neurology world, or acute neurology or neurocritical care world, or neurosurgical world, that is not the world that we live in. And that's problematic, and that's concerning. And for many movies, is that concerning? Fortunately, there are several ones that really are well done. For example, Amour, about stroke management of a patient who had stroke and all the complications of stroke in the elderly, and how they do when they go home. And there are, of course, a lot of films about Alzheimer's disease. The Father was a recent very good one to look at, that for at least for neurologists is of interest. So this I can go on talking
No,
about
no.
movies for a long time.
That's great. Maybe we'll just to wrap up here. I'm wondering, you've really started neurocritical care at the Mayo Clinic. We're now, 30 years on. What excites you about the future of neurocritical care?
Yeah, what's the future of neurocritical care? That's a good question. I wish I knew. I think the future has to be is that we have neurointensive care units in more countries in the world. I'm still surprised that in the UK there are very few neurointensive care units run by neurologists. There are many countries in the world where neurointensive care, or the whole concept of neurointensive care, is non-existing. And I think that's continues to be, I think, should be a major task to have a more global representation for these patients, because I don't think they're managed well if they're not in a neurointensive care unit, not taken care of by neurologists or neurointensivists. I would think that would be our next step in trying to make that happen. I don't know what the future otherwise will be. I think there's definitely challenges in maintaining the adequate workforce to continue to what we're doing, because it's hard work, and I think many of the fellows may not appreciate what they're going into. It takes a long time to do what you want to do, but it's a very consequential specialty, and it's something that we can really help patients in a very significant manner.
I agree. To do that, we're going to need to train a lot more fellows. And what we've seen over the last several years is sort of a plateauing of the applicants into the
Yeah.
fellowship. Although the number of training programs has increased and the number of fellowship spots has increased. Any ideas on how we get more people interested in providing the care that you're suggesting is needed?
Yeah, it has to come out of your own residency, I think. And we had a period that there was very little interest, but now we have every year neurology residents, and we've always had only neurology residents. We trained, I think, the only maybe the first neurosurgeon giving a neurocritical care fellowship. He's now became an anesthesiologist. I think he did neurosurgery and then neurocritical care, and now he became an anesthesiologist. Multiple boarded. But we always felt that neurologists should be in our program. I still feel personally that neurointensivists should be, that the base of neurointensive care should be neurology. There should be a good, solid neurology or neurosurgery basis to a fellowship. And that has to come out of your residency, I think, and just trying to get many of your residents come into the ICU and have them rotate in the ICU. We do that, of course, for our residents, and they enjoy it, and many of them just feel that that's the path that they want to take.
Great. We finished with just a couple of quick hit questions. I'm wondering if you can complete the following. So, my purpose
has always been to improve the patient's outcome.
I recharge by
watching movies. It's not a surprising answer. I read a lot. I watch movies a lot. That's in the time that I've left. During the day, that's what I like to do. I think we watch probably every night. Watch a film.
I love
my family and my wife for many, many years. We're now 45 and counting.
Wow. And I want to be remembered for?
I think we should be remembered, and it's not me, because I don't like heroes or put names to a specialty. I think we should be remembered that we found out that there were patients that needed specialty care, and that we needed to figure out how they were behaving in an ICU, behaving in the sense how their trajectory was, and how we could best manage them. I think that's how I would like to be remembered, that I contributed in some part to it.
Wonderful. Our final question. What advice would you give to the fellow about to graduate?
Yeah, I said that before already. I think, again, it's just my own experience too. It's that once you finish fellowship, you need to understand it takes at least 5 years to become an average neurointensivist. And it may take 10 years to become a good one, and maybe 15 years to become a really good one. It takes a long time to get there, and don't be discouraged by it. Try to see as many variants of disorders that you can see, and be there when it's presenting to you. But it takes a long time. It's not. I've done my residency. I've done my fellowship, and I'm now a full-blown neurointensivist, boarded and ready to go. It takes at least 5 years, 5 to 10 years to get to where you feel reasonably confident that you can handle difficult, stressful situations where there's often a major intensity and an immediacy that you have to be aware of, and often in the middle of the night.
All right. Dr. Wijdicks, thank you so much for joining us on the podcast. It's really been an honor.
Thank you so much for inviting me.
All right. This has been the Neurocritical Care Society podcast. We can be found anywhere you get your podcasts, including on the Neurocritical Care website. Select continuing education credits are available for select episodes. Please like and subscribe, and we will hopefully have you join us next time on the NCS podcast.